on purpose. So, hello, people. Alrighty, it is time, so we'll go ahead and get started. So let me kind of let you know where we're at with things. So today we are going to go through your responses to the assignment about informal assessment. We are a little behind, but that's okay. We'll start diagnosis and probably finish it. So I'll eat a little bit of the group project day on Friday, but then you will have time to work on your group projects that day and Monday. I'm planning to be here in person, so please plan to come or at least drop in so that I can answer any questions that you have. This really is for y'all. The other thing you can use this for is if you and your partner are behind, like you didn't do the R bands or you didn't get the back and all those, that's a nice chance to start catching up on those. Hopefully, we'll see how many people are here those days, because I know it is tentatively close to Thanksgiving. One of the things you're going to do is do interviews with each other. So we'll either look at that Friday or we'll wait till after Thanksgiving when people might be like re-energized. The assessment report I've given 2 days in our schedule, but it really only takes one to cover it. So we will be good there. Exam 4, I'm going to try to have posted before Thanksgiving. It's going to be the same way 2 and 3 were, where you take it home. You can either just fill it out in a Word doc and upload it, or you can bring in a hard copy. So I just have to like tweak some stuff from the in-person version, basically. I really like you all being able to do that. You've been doing better on the exams because of that. So I think going forward, that's how I will teach this class. So, you know, good weird thing is to come out of me having COVID. I figure out what works better for this course.
We are going to be here on Friday.
Yep, on Friday and Monday, plan to be there. And I will be available and, you know, can consult with groups or partnerships that need to work on things. So, it'll be, you know, use that time wisely because it's basically free time for you all to work on things. And if anyone is ready, it's at the point where you're ready to go analyze your data, you can go over to computer lab and help you with SPSS as well. Or if you just bring your laptop and have it downloaded there, I can help you. Already, any questions about the end of the semester? So after exam 4 is due, you'll have another group project work day. Probably will make the day that you would have taken exam 4 in class another group project work day, depending on where we're at with things. And again, to catch up on things like the interview and whatnot. So you'll have lots of time in class. You'll have almost 4 hours over the next few weeks in class to work on that group project and the stuff for the assessment report project. The assessment report project ends up being pretty cookie cutter. So hopefully when you all go to do it, you won't find it that overwhelming. That's always my goal, is to make it fun and a little bit of a replication of what it's like to do it in person, but also not like overwhelming, if that makes sense. Alrighty, so let's go ahead and start by going over the assignment. And for those of you who may not have been here on whatever day that was, Monday, this is what we did. So box 10.1 on 220 described a class of kiddos that like constantly had people coming in to observe them. Right, and so like that was disruptive in and of its own way. And so I'll just throw it to anyone in the class. Yeah. Oh, okay. That's all right. Whatever page it's on. How can we avoid or fix a situation like this? Throw it to anyone in the class. What your group responded or just your gut response to. How can we avoid? How can we like do the observations we need to do to help kids and or do research, but also not disrupt their educational experience? Yeah. Yeah.
You have to wear the t-shirt sometimes. I think it also helps.
Definitely. Yeah, I have a friend who used to be an ESL teacher, and she would actually like take the kids out of class to look at them during one of her period, and she said that ends up being really helpful to be able to put one on them. Yeah, that makes sense. Other thoughts people had. Yeah.
You know, if you're kind of cameras set up, and you can observe remotely, obviously, yeah, like maybe,
Yeah, that's such a good idea, especially given the technology we have now. So, I mean, when I was finishing grad school, almost 15 years ago now, like we had cameras that were pretty slim then. I'm sure they're even tinier now, right? And so like in one of our therapy rooms, we had like one in this corner, one in that corner. The room was much smaller, actually. And so you would get like the way the video would show would be a side by side of like an image of the therapist and an image of the client, which is really cool. Yeah, and then like our group therapy, family therapy room, there was just one camera that was kind of fisheye, so it's got the whole room. So yeah, this is definitely a way to do it. And then you can either sort of watch it as a live feed on closed circuit TV or record it and look at it later. Yeah. Anyone else come up with anything else? It's a great idea. I think the only other thing I can think of is if anyone's ever been in, I think it's Prudent over in the village over there. One of the classrooms over there in the ed department has one of those one-way mirrors. So that's another option, although if that's there, people do know they're being watched, and so their behavior can actually change as a result of just knowing that, right? Yeah. All right. What are ways to use observational techniques, thinking about event sampling and or time sampling? And again, throwing this to anybody. The plane can answer. Very loud. I'll just give you some examples. This is used a lot in research now. And for time sampling, the vast majority of times it's now on an app on your phone. You just download it like you would any other app, and then the app signals you at random times throughout the day to see, fill out this questionnaire. But it might also prompt you to do it when a certain event happens. So I think I talked before about my friend who did it when someone worked out, right? But I had another colleague who was interested in self-injurious behavior. So there are people who are not engaging in suicidal behaviors, but might engage in self-injury, like cutting themselves, things along those lines. And so he had a study where there was the time sampling, but then there was event sampling. If they engaged in an element of self-harm, they would stop and report that, obviously, once they were safe, if they needed any medical attention. So, yeah, there's lots of different ways you could do that, with the kiddos. I can imagine, watching the tape all day versus like just looking at when X kiddo acted up, right? Or maybe you only look at, how do they act in gym class versus recess, right? And it's an unstructured versus structured environment where they do similar things. How about rating scales? How could you use rating scales in these scenarios? Yeah, something.
I know we talk about like, I know when I was younger, they'll have like the different color cards, like the yellow, the green, and things like that, to see how you were acting during the day. So instead of like using something like that, the rating scale, like with your emotions, to see if like, during the morning time, if you were happy, did your mood change during recess, lunchtime, something like that, just trying to keep up with the mood throughout the day on the rating scale to kind of see like where the child is, and if it's like approving, if they approve whether he or she goes, or if it's like, things like that. So that was one way we discussed it.
Yeah, I think that's such a good idea. Or like, yeah, people will just use like a smiley face scale, right? They use it for pain, but also for emotions. Something that the kids can relate to, right? Especially if we're thinking about kiddos. Yeah, yeah. All right, if you were in therapy and your therapist came to visit your home or work environment, would they learn something different about you? What might you neglect to tell your therapist? Or why might you neglect to tell your therapist certain things about you from your home or work environment? And how useful would that be in revealing the true you? And this is, anybody can answer just sort of what you think that experience would be like. Yeah.
Okay, so once again, we bring up how sometimes people change in their home. Cause like I know I use it as example, like when I was younger, my grandma would be like on the phone a different way, but she'll be talking to me a certain way. And like if something comes, she's like, oh, hey, how you doing? I'm like, you were just yelling. Like, so things like that. So we were saying in like the group, like depending on the therapist, if it's a new therapist and it's a new person, they're trying to make a good impression versus if you have a relationship, like a good friendship with your therapist, that you might be more comfortable. And also we discussed that sometimes in your own house, you're more comfortable versus going into like an office or something like that. And then some things you might neglect is probably like the bad thing because you don't want things to go too far. Because some therapists, if you're saying like self-harm, or if you're saying like domestic abuse or something like that is going on, some people might want to not say that because they're scared that they'll like get the other person in trouble or something like that. So it's kind of like counseling, like you don't want to say too much because you don't know if CPS is going to get called. Right. So certain things that you might say depending on the relationship.
Haley, did I see your hand?
Yeah, we basically talked about the same thing. I sort of talked about like when I was younger, like I got put into therapy for something and I was really not therapist. So like I would talk to him, I just went to him on the top of it. And I was thinking that I would do more like
right, yeah.
It's like basically, I know I act different when I'm at home by myself, and even if I'm at home, if there's people around, depending on who's around, I immediately adjust my behavior, and at work, I'm a different person. Yeah, your therapist, especially if they're a good therapist, them seeing those other sides of you would help them to like for some things that may be going on. But when it comes to like neglect, I noticed a lot, especially in our age group, a lot of people don't want to bring up like suicidal ideation with their therapist because like the stigma is like, oh, they're gonna send you to like the psych ward, like it's like, well, you can share that with your therapist,
Right.
just to a certain point. Like you can't be like, oh yeah, I am actively thinking about this and planning it. Instead of like, yeah, these thoughts come up, and I'm trying to move past it.
Yeah, in fact, your therapist wants to do that so they can help you figure out the best ways to act when that happens. Yeah, that's a huge fear people have. But yeah, as long as you can say to your therapist, I'm good between now and the next time I see you, right? I'm not going to act on these. Your therapist will be fine with it. We used to engage in a process we call contracting for safety. If someone had very suicidal thoughts, and it was just a piece of paper where you had them write down 3 things they could do if they got to the point where they thought about acting on those ideation. You would sign it, therapist would sign it, it would go in your file, and then not only would you have something that like the therapist is like, you're good, but also then you have strategies you could use to make that really overwhelming, right? Yeah, I think that's a really good point.
I know with me, I mean, thing that I haven't done for that much because I'm gonna including all of the things that I do wrong. But like, my space at home is a disaster. I live in such a mess because I have depression and cleaning is the last thing that I want to do when I get home after school or whatever. Like I just don't want to deal with it. So coming to my space, you would see that and be like, wow, you need help. This is true.
Yeah, I think that Debbie, you kind of bring up a good point that sometimes it's not even that people don't want to disclose things, it's like they don't think of it in that way. So like, you might not, if you didn't have as much insight as you have, right, you might not think about your messy space as a manifestation of your depression, right? Or the opposite, sometimes people who are depressed, right, will think there's nothing good in their lives, right? And then you might observe them at home or work and you're like, actually, you're kicking butt, right? So yeah, I think that's a really good point. Yeah, and I mean, this is hard, right? It's hard for therapists to do this, but social workers often do this type of thing, right? And they can make it work. And then how did you all think of using records and personal documents and whether those would be helpful to the therapeutic process? So this could be like school records, health records, it could be like journals, things along those lines. Yeah.
I think those, being able to do those definitely helps develop psychological. It doesn't hurt. I feel like you don't even know. Like, if I just sit down with your client, I have. Travel is just.
Yeah, I think that's such a good point. Yeah, and in particular, types of assessments, it's almost bad practice not to do these. So like if you're assessing a kid, right, you want to look at their school records, right? You want to look at what the teacher's saying, this is what the parent's saying. The kid might be totally different, just like we were saying for adults, the kid might be totally different at school than they are at home, right? And if you're doing a forensic assessment in the legal system, you like have to get records. Like no matter what kind of assessment you're doing, you have to get records, you know, and again, it could be school records, it could be criminal records, it could be they've had previous therapy, and you get those records, that type of thing.
That also, you know, understand their cultural background
Oh, yeah.
and demographics and that can help you understand, you know, where they're coming from and things that are, you know, different between like what we consider normal, what other people consider normal. And so that's also important to know what is actually happening.
Yeah, I think that's also a really good point. One of my very first clients when I was a grad student was, and she was always very specific about this, Egyptian from Cairo, because that makes a difference. And she wore the hijab, and she had an arranged marriage, and those were not things that I was familiar with, obviously. And so I did some reading, and then I just realized, like, this is not going to be that helpful. So I just had her tell me her story. What does your faith mean to you? What does wearing the hijab mean to you? What does your arranged marriage mean for your life? Right? And those things were really helpful. She liked that I asked rather than assumed, right? So sometimes you kind of have to humble yourself, especially when you're a young new therapist, right? Sometimes you would want to be like, oh, I'm the expert, I know everything, right? And just admit, like, I really want to hear about this from your perspective because it's an area that I don't have as much knowledge in. And clients are actually really receptive to that usually. Great thinking about these things, y'all. Yeah, these are important things to be thinking about and thinking about the implications for therapy of these things as well. Alrighty, so I am going to start our presentation. Those of you who have taken abnormal, or what we now call adult psychopathology, some of this might end up being a little bit of review for you. But those of you who haven't, no worries. We're going to get at least an overview of it. Drag this out of our way. All right, so this part I kind of split up. So we're going to make this more about diagnosis. And so we can skip the vignettes, but just thinking about diagnosis and why do we have to put a label on someone? And just to let you all know, this is a controversy within the field of psychology. There are psychologists who say we should just treat the symptoms rather than putting a label on them. And I totally get that. But there are reasons why we have to give them. So certain federal laws, particularly those surrounding education or other accommodations, require a diagnosis. Third-party payments, we're basically talking about health insurance here. If you are working in a practice where people are not paying out of pocket or it's not covered by some other entity, you need a diagnosis in order for the insurance company to reimburse you, right? So this was especially frustrating for me, having been in my training clinic where, as I've explained to you, we had kind of infinite time if we needed it to diagnose the person at the beginning. We would do an intake interview, then the diagnostic interview. And then we'd give them the MPI and like, we could take our time. When I got to my internship and I was at the medical hospital, like everyone had insurance. And it was like, you had to come up with a diagnosis by the end of your first session with them because you had to write it on the form you turned back in to the front desk when you walked that person out. And so that was frustrating and challenging. And, you know, you have to learn how to kind of like do what you did previously in maybe 3 hours in one, right? So the other way is that it communicates with other clinicians, right? So there were several people I would see who also had psychiatrists, for example, that would prescribe their medication. If we had that diagnosis, that means something to clinicians. Like if someone has this, we approach things in certain ways. We know that many diagnoses are biologically caused. Many of them have strong genetic components, particularly the mood disorders, for example, depression, bipolar disorder, even more so. And more, we're finding a lot of disorders are either partially or largely caused by neurotransmitter imbalances in the brain or other brain-based issues. So that are influenced by what goes on in society, don't get me wrong. But we need to think of it in terms of, you know, I think I might have even worn this graphic tee one day teaching you guys on a Friday. I have a graphic tee that says mental health is health, right? Like, it's the same thing. It hasn't traditionally been treated as the same thing. And having diagnoses helps us work within that system. Now, does that mean that that system is the best system? Absolutely not. The medical system has its flaws, right, for sure. But it at least, again, allows that communication.
I think sometimes for certain clients, it is having that label is important, validating. And so like, you know, this is what I have, this is what's going on versus just treating the symptoms. It leaves you kind of hanging. And so having that definitive diagnosis gives you validation.
Yeah, I think you're spot on. For a lot of people, it's like, it's exactly like if you have been struggling with medical issues for a while and then you figure out what it is. Like I'll give you guys probably a weird example, it might be TMI, but hang with me. I had a lot of gastrointestinal issues when I was in grad school and we were trying to figure out, was it acid reflux? They checked me for gallstones, right? Did all these things. And then it was like around this time of year when I was working with the nurse practitioner, and I went home for Thanksgiving, was totally fine, like gorging on all the normal Thanksgiving food. Came back to campus, I had to give a presentation in our lab meeting and it acted up again. So based on that information, we were able to figure out that it was irritable bowel syndrome, which was actually really highly related to stress and anxiety. Getting a name for it meant, yeah, I could figure out what it was and I could get diagnoses and things along those lines. The flip side, I think I can really only think of one client I had who freaked out when I told her diagnosis. And it was because sometimes this is, as much as it's obviously great to be educated in psychology, sometimes it's a drawback. She was a counseling psych grad student, so she knew the implications of being diagnosed with a personality disorder. And so she freaked out. And so like that session had to turn into like support for her. Yeah. Right. Yeah, I mean, when I teach adult psychopathology, it's like, I try to remember to say at the beginning of the semester, like you're going to experience med student syndrome, which just means everything we read about, you're gonna think that you have, right? You don't have all of them, I promise. And that might happen to y'all as we go through, you know, even this brief overview. You don't have every diagnosis in the DSM, I promise. I promise. But yeah, that's a really good point. And it could be so funny because like it took me forever to admit I had postpartum depression after my daughter was born, like literally crying. He's like, I have to watch myself for postpartum depression. It's like, I have a PhD in this, like I should have more insight, right? But it doesn't always apply to yourself. Yeah. You could also use it to help think about treatment planning. There are certain treatments that are designed for certain disorders or adapted for certain disorders, and thinking about, you know, the best ways to approach things with a person as well. All right, so I have the information about the DSM-4TR, which is no longer in use, but I think it's important to kind of know where we came from, and this is less than 10 years ago. We changed in 2013. So we used these 5 axes at that point in time. We no longer use these, so don't worry about memorizing these. I liked this system though, which is why I'm going to talk about it. Now you just kind of like write down all your diagnoses. But I really liked this in terms of it was an overall conceptualization of what was going on with the client. So axis 1 is the disorders we would traditionally think of as psychological disorders, depression, anxiety, PTSD, eating disorders. All those would fall up here. Axis 2 is personality disorders, and we don't even use the term mental retardation anymore, it'd be developmental delay now. But things that were longer term, underlying, harder to change. What I really liked about axis 3 is we consider medical conditions. So now we do it, but in a much less formal way. So for example, you've got a client with depression. And then you probe more and you find out they've just been diagnosed with cancer, right? Like those two things are clearly interacted, right? So I think that that's so important, particularly if you're working in a medical setting. And then we also look at psychosocial and environmental problems. Is this person going through divorce? Does this person just start school or get fired from a job, right? And then there was a 0 to 100 global assessment of functioning rating we used to give that would tell you essentially how that person was doing overall, higher is better. All right, so the DSM-5, as I mentioned, was released in May of 2013 and did away with that system, much to the chagrin of people like me who liked it. And the other things they did are major revisions to the criteria for existing disorders, and new disorders were added. And they've actually just said recently that they are going to come out with a DSM-5 text revision, like they had for the DSM-4. So the TR text revision is kind of like in between. So it's like we're not quite ready to overhaul the whole thing and make a DSM-6, but there's stuff we need to address, basically based on updated research. So that'll probably be coming out in the next couple of years. And so some of the changes are great. Some of the other ones are problematic. I'll give you sort of my opinion, but also based on the research as we go through and talk about them. Here, we no longer talk about axis 1 versus axis 2 disorders, so the personality disorders would just be listed in the same place as your other diagnoses. And each mental disorder covered in any modern edition of the DSM describes the disorder's main features, if there are any subtypes or variations. So sometimes, for example, major depressive disorder, you can have single episode or you can have recurrent. You can also designate by severity of symptoms. The typical pattern, course, or progression of symptoms. And then probably what's the most helpful, in addition to this, like the symptoms themselves, is differential diagnosis. So if you have someone who has these symptoms that might look like another disorder too, how do you parse apart which one they have? So the DSM-5 is written by the American Psychiatric Association. Any organization in the US right now, unfortunately, going to have the majority of their leadership be cisgender, heterosexual white men, right? And so because of that, some of these things are not taken into account the way they should be, in my opinion. So things that aren't diagnosable are client reactions to expected culturally appropriate reactions to life events, like loss of one or depression. But in DSM-5, they actually changed it. They used to be if someone had recently had like a loss in their life, someone passed away, you couldn't diagnose them with depression for 6 months, and they took away that criteria. So in some ways, people see that as pathologizing grief and problematic, right? In other ways, it means that someone who is maybe having an overwhelming grief reaction, that means they are not able to like fulfill their daily life, can get help sooner in theory. Yeah. Exactly. Yeah, because some people get to the point where like they're not working, right? They're not fulfilling family obligations, they're isolating themselves. And so like we want to get that and still let them breathe, obviously, to give that person the best quality of life that's expected or acceptable in that moment, you know. There aren't phase of life developmental issues. There's no like midlife crisis diagnosis, right? Culturally specific reactions that might seem unusual in Western culture, you know, we just kind of don't take that into account in the DSM-5, which is problematic. And a lot of like problems with living, to borrow a phrase from Thomas Zaz, who was a psychologist working in the 50s and 60s. You know, aren't diagnosable, which in some ways is good, because again, we're not over pathologizing, but again, in other ways might make it more difficult for you to get help. And those who have a diagnosis most live relatively normal lives, right? So I think that's important to know as well. There are some acknowledgements of differences in presentation in terms of gender, age differences. So for example, if you look at depression in kids, they might not be able to say they feel sad, but it might sort of manifest as being really irritable with everybody around them. But it does include an appendix of cultural specific client experiences not included elsewhere. So an example here is poro, which is a term of Malaysian origin that's an episode of sudden or an intense anxiety that the penis, or in females, the vulva and nipples, will recede into the body and possibly cause death. That's not a thing we necessarily experience in the States or in most Western societies, but there's an acknowledgement that this exists, right? Again, though, we do have to acknowledge the Western-centric bias. And so, for example, there have been proposals in the past to suggest that the eating disorders might be culturally bound to Western societies, because we don't see them manifest in the same way anywhere that doesn't have, say, Western media, for example. And in fact, there are studies that showed that like when TV was introduced to Fiji, the number of eating disorders went up exponentially. Like there was like maybe something that kind of looked like an eating disorder that was culturally specific before that, and then they started developing actual eating disorders. So, but because again it's Western centric, they're like, no, that's normal, that's not culturally bound, so that's problematic. Here is a gender issue case study. So I hate this diagnosis with the fire of 1,000 suns. That being said, there are rare cases where having this diagnosis helps people get treatment, and I fully acknowledge that. This is premenstrual dysphoric disorder. This is essentially pathologizing extreme PMS. And so you have to have 5 or more of these symptoms. One of them does have to be 1, 2, 3, or 4, which is a change they made to DSM-5. This was in the appendix of DSM-4, and they didn't include that, so that makes it a little better. That it has to essentially be mood related. So you're showing depressed mood or anxiety, or you know, affective lability is essentially kind of like bipolar type symptoms, or anger, irritability. So we do now fully acknowledge you have to have these mood changes with it. It's actually considered a mood disorder. That being said, a lot of these other symptoms are potentially just normal things for people who have periods, right? So, you know, lethargy, marked lack of energy. This is my favorite, marked change in appetite or specific food cravings. Like, how is me wanting chocolate, right? Diagnosable. things like being bloated, right? Again, like they have clarified it enough that it is diagnosable in a specific way. And there are people who essentially get depression or bipolar-like symptoms with their periods that this is helpful for. And again, I fully acknowledge that, and I like the changes they've made. But if you step back and you give this to like a primary care doc who doesn't have specialized training, in theory, anyone with a uterus could end up diagnosed with this in some way, right? And that's what's problematic. I should say RIP, Pollock Kaplan was a psychologist who just passed away maybe a month or two ago, and she was really against this diagnosis and tried to like submit an equivalent one for men, essentially, that was about like testosterone, something. And again, because of who's in charge of these things, that's kind of dismissed and poo-pooed. But it's really sort of interesting to think about who gets pathologized. Yeah. Right.
You have low levels of it or even high levels of it, like you're overconfident.
Exactly. I mean, like roid rage is a thing for a reason, right? Because like that much adjusting your body's biochemistry, particularly with hormones, does create changes in how you interact with people. Yeah.
That's kind of concerning that like even after people are faced with this, because like just read some of these, like it's obvious that a straight white man was
Right.
a lot of what was written here, so it's just, it doesn't make sense.
Yeah, and it's frustrating. And again, like when I've asked people about it, they've said like, again, there are these rare people who need this, right? And that it's actually helpful. And so I want to fully acknowledge that if anyone in here knows someone or is someone who has been diagnosed with this, I respect you, I see you, I'm glad that there's something that can help you. But like, I feel like there's gotta be a better way, right, than pathologizing normal female body, or again, bodies with uterus symptoms. And like you were saying, testosterone does affect men, and testosterone cycles more quickly in men. So like you have daily cycles instead of monthly cycles. So I think if we are gonna have this, we should have equivalents for people without uteruses.
So the only time I was living in a different state and I saw one doctor who was a male OB/GYN, and he told me this is what I had the first time that I ever saw him. I was having like bad periods and like, you know, he's like, oh, you have this, and like, it's just everything. And it's like he was an old white male, very like misogynistic.
And again, fully acknowledging there are good male OBs out there, right? But yeah, that there are these people who are problematic who think this way, right? And in general, I think, unfortunately, the medical field and psychologists are just guilty of this. If we get a diagnosis, sometimes it's hard for us to see beyond that and to realize there might actually be something else going on. So for example, one of the things that happens with men is they'll come in and they'll be diagnosed with like substance use issues, substance abuse. And in fact, what's often underlying it is depression, right? But that depression never gets diagnosed and treated because we're just looking at that surface level. And so I think that's really problematic and something we need to work on as a field for sure. So again, axis 1, axis 2 are not actually things anymore. But what I do want to do is start walking you through some of these diagnoses from DSM-5 as it exists right now. And I'm pretty sure I have yeah, I have slides for each of these, so don't worry about scribbling down all these categories. But these are the categories that are in the DSM-5. And then again, what we used to call axis 2 are these long-term disorders, and which treatment might have little to no effect. That's less and less true for personality disorders, which may be one of the reasons why they got rid of this designation. There are very good treatments, particularly for like borderline personality disorder. And in fact, there have been celebrities who've come out recently speaking to the effectiveness of some of these treatments. So both Lady Gaga and I believe Selena Gomez have come out and talked about dialectical behavioral therapy, DBT, which is used to treat this, and very effective. And so again, what we used to call mental retardation, we would now call developmental delay, is intellectual functioning below the second percentile. Okay, and so you would have anywhere in this range of, based on your IQ, we know that these things sort of correlate with what you're able to understand and accomplish in your life. And it doesn't mean that if you're in this category, you can't have a fulfilling life, right? So if you think about, I don't even know if they're still utilizing these folks in the pandemic, but you know, the like baggers at grocery stores who are often these folks, right? They often seem very happy to have a job. I was actually super sad because I think it was right before the pandemic. There was a gentleman who would always take the tickets at the cinema cafe, whatever here in Pembroke, and he passed. And that was really sad because he was always like someone that put a smile on your face for the whole day, right? And so we'll talk about the personality disorders a little more, but these are more inflexible or enduring patterns. And as you can see, there's a whole host of these. Cluster A are the odd or eccentric ones. These are most similar to schizophrenia, but they aren't schizophrenia, if that makes sense. Cluster B are dramatic, emotional, overly sensitive, and erratic. And that's where that borderline personality disorder falls, and also antisocial personality disorder, which is the disorder related to psychopathy. So psychopaths are typically diagnosed with this. All your serial killers, those lovely people, right? End up with antisocial PD. And then cluster C are anxious and fearful traits. Alrighty, so now we're going to start talking again, very surface level, about the different categories and disorders in the DSM-5. If you want to know more about this, take adult psychopathology. We're offering sometimes now a topics course on child pathology as well. So we're trying to really expand what we're offering here. But we're going to talk about these used to be called disorders diagnosed in childhood. But we've now changed the title, and I do like this, to neurodevelopmental things, because that really acknowledges that these are brain-based, right? As opposed to like, they disappear, we don't know why, right? And talking about that. So things like what we used to call mental retardation will fall under intellectual disabilities now. You can have intellectual developmental disorder, global developmental delay. And what we'll see throughout is a lot of times you can have an unspecified. This is basically like you have all the symptoms almost, you don't quite meet criteria for, you know, in this case, intellectual developmental disorder, but you certainly have something going on enough that we want to diagnose you so that we can get treatment, basically. So these sort of catch-all diagnoses allow people to get treatment who don't meet full criteria for certain diagnoses. That existing treatments for those diagnoses would still help. Communication disorders, so you can have language disorders, speech sound disorder, fluency disorder is what we call stuttering. You're like, why are some of these even psychological diagnoses? Well, a lot of times stuttering, for example, is related to anxiety that the kid is experiencing. And social or pragmatic communication disorder. So this would be more, they communicate just fine, except if they're in social situations. The autism spectrum disorders are all under this one diagnosis now. This is very different than DSM-4. We used to have Asperger's syndrome as its own diagnosis. That is now umbrellaed under autism spectrum disorder, for example. ADHD, so just mini history of ADHD. Once upon a time, it was just called attention deficit disorder. They added the H, or the hyperactivity, to acknowledge that these behavioral things are a big piece of why this is disruptive for the individual and those around them. So you can have ADHD, or you can have other specified, so something that might not be diagnosed as much, but we have a name for it, or unspecified. Then there's the specific learning disorders, the one we always think of. Oh, yeah, sorry.
I just think like with ADHD, like one thing I'm very sure that I just don't feel like sure that because like I remember like I haven't taken any medicine for as of recently, but I remember I went into the doctor to get re-diagnosed, and like there was just like this questionnaire, like basically, do you interrupt people a lot during this conversation? Just all types of things, and they're like, well, you're ADHD, especially when it's like, it just didn't help that much. But I feel like it should definitely be like re-diagnose people. Like, it should be someone fully trained, like,
Yeah.
should have a regular doctor.
Yeah, I think Kariana is bringing up a really critical point here that people would argue for most psychological disorders is that most commonly they are diagnosed by general practitioners, and that shouldn't necessarily be the case, right? So even something like depression, the vast majority of prescribed antidepressants are prescribed by primary care doctors, just because that's who people go to see. And that's maybe fine if the person, like has sort of a moderate level of depression. But if they're in severe depression, you really need to be careful about that, right? You need to think about like, are these pills they can overdose on? And if so, we need to not do that. And when you get into some of these other disorders, like let's say bipolar disorder or schizophrenia, like you for sure need to refer because like, I'm a psychologist, not a psychiatrist, even I don't know the nuances of like how you titrate lithium so you don't get the person lithium poisoning, right? Or get the right amount of antipsychotic so the person has their symptoms alleviated but isn't experiencing the side effect called tardive dyskinesia, where they're like constantly licking their lips and engaging in other tick-like behaviors, right? So yeah, I think that's such a good point that we need people who are knowledgeable in this type of diagnosis to be making these diagnoses rather than generalized practitioners. So for that reason, not all, but a lot of essentially in larger settings like the VA, for example, a lot of primary health care clinics are now integrating psychologists into their clinic. So if they might have a mental disorder going on, your doctor could just walk you down the hall and that person's right there. You don't have to worry about, is that person actually going to follow up with the referral, right? So I think that that's such a good plan, and I hope that that really continues to be the wave of the future so that we can have that integration, we can have that support. The VA, I think, is a really good model for this. I want to say I worked on like 4 or 5 interdisciplinary teams while I was there, and I really think it serves the patients well, right? Like, so for like someone who came in with a traumatic brain injury, we would have the neurologist, me as the psychology resident, a social worker, and a nurse all meet with the person together, right? And then I would like take them to the side to do quick memory screens. And then we could talk about it together. We could talk with the patient together, and they got everything all at once, right? And I think that's so important. It really should be the wave of the future in terms of interaction. Already, you all are giving me great questions, great comments. So this is awesome. So plan on us probably taking most of the class on Friday to talk about this. But don't forget, sorry, that you will have an extra group project day on the day you would have taken the exam for in class. So I'm making up for it, I swear. All right. Great job, everybody. And I will see you on Friday. Yeah, all you do is just speak to them, basically, and then, yeah, I would say for sure, set it up to do it online. Yeah. Look at so much back surgery, and then just like spam your stuff with it. Yeah, so teach that bit and just send it to me, and then, yeah, we can just start setting that up and go through there. You're welcome.
I have a question. So, all of this is together, but